السلام عليكم ورحمة الله وبركاته. نكتمل فيديوهاتنا عن الكدني ترانسبلانت بيزك كلينيكال بيرلز. توكلنا على الله. النهاردة هنتكلم عن ال early post transplant complication، العيان لما بيزرع الكلى أو post transplant surgery. معظم المرضى هتروح تبص على المريض في حاجة اسمها delayed graft function. هم المرضى اللي طبعا اللي ما بيجيبش not making good urine output and electrolyte worsening and serum creatinine increasing, especially hyperkalemia and increasing creatinine, no urine output, patient whatever, uh, daily increasing, and then risk for heart problem or cardiac arrhythmia from electrolyte disturbance, and patient urea start to increase, creatinine start to increase with uremic symptoms. This patient maybe will need dialysis during the first week post-transplant. And this delayed graft function related to some acute tubular injury and ischemia reperfusion injury. And this commonly and most common disease after cardiac donation, as we mentioned in the previous lectures. Primary non-function kidney immediate graft failure due to technical complication, arterial venous thrombosis. We can see all this in living donor kidney or live kidney donor, especially if the donor is making a lot of urine before and they start to be just a little bit urine or no urine output, and or especially patient anuric, the most important patient anuric before transplant, and he got a live donor kidney transplant and is not making any urine in recovery room or PACU. Post surgery should do a stat ultrasound to rule out surgical problems. It's rare to see hyperacute rejection by the technique of the HLA now and the blood grouping. It's rare to see any hyperacute rejection at the moment. Immediate post-transplant management for delayed graft function, multiple definition. As we know, just put in your mind, the patient need dialysis, the recipient need dialysis in the first week post-transplant. And you can see this less percent patient after live donor less than 5%, but in deceased donor 30 to 40%. Donation after cardiac death around 50%. Maybe you need dialysis for the first few days, sometimes weeks, sometimes months after transplant until the acute tubular injury recovered. Other risk factor, donor age, cold, warm, ischemia times, perioperative hypotension, and recipient vascular disease. Cold and warm ischemia time. Cold ischemia time, this is the time once the kidney taken from the donor and kept on ice of box of ice or putting on the pump machine. And warm ischemia time, once the kidney taken from this box of ice until declamping and start perfusion after anastomosis and the new recipient. Common causes for delayed graft function is a pre-renal, renal, post-renal, pre-renal hypovolemia, especially for the recipient, little bit soft blood pressure, less perfusion to the kidney, post-operative pulmonary embolism, MI, other complications, CNI toxicity, other non-steroidal ACE inhibitor, no one using now, but sometimes used by mistake, and renal artery embolus or thrombus. From renal causes, venous arterial thrombosis, post-ischemic reperfusion injury, acute tubular necrosis, hyperacute or accelerated rejection, it's rare to see at the moment, and post-renal either ureteric stricture, lymphocyte, urinoma, hematoma. This complication is common post-kidney transplant. What investigation you should do for any patient with delayed graft function? Just assess volume status, check your CNI level, check preoperative cross match, obtain transplant stat Doppler ultrasound to see the kidney perfusion and rule out any pre-graft collection. And we should consider biopsy after 1 week if all other causes no signs of recovery, and you rule out all other pre-renal causes and post-renal causes. Management: ensure adequate, effective circulating blood volume. Your patient should be euvolemic or a little bit on hypervolemic side, not in hypovolemic side. Hold any nephrotoxic drugs as possible. Reduce tacrolimus or CNI levels. Address any specific post-renal complication or rejection. What is the risk factor for post-ischemia reperfusion injury? Prolonged cold ischemia time. Prolonged more than 30-minute warm ischemia time. And deceased after cardiac death donor likelihood is 75%. Increased donor age with extended criteria donor, as we mentioned in the previous talk. Nephrotoxic agent pressures contrast dyes in the donor. Subarachnoid hemorrhage in the donor. Vasculopathy in the donor or recipient. All this will increase more risk of ischemia reperfusion injury. And the dialysis post-transplant, either hemodialysis or peritoneal dialysis. Hemodialysis, you should avoid any hypotension or excessive fluid removal, or no ultrafiltration is better with heparin-free and low QP and QD, low blood pump and dialysate pump. And the peritoneal dialysis can be done if the peritoneum not breached or pricked or injured by the surgeon, transplant surgeon during his surgery. You should ask the surgeon for any patient on peritoneal dialysis, the peritoneum is still intact to be used after transplant or not. How to manage delayed graft function? Just like conservative management, careful attention to his blood pressure and volume status. Keep the blood pressure and volume status on hypertension side and hypervolemic side. Avoid any nephrotoxic immunosuppression medication and other nephrotoxic drugs. Dialysis as needed until renal recovery occurs. Imaging of transplant ultrasound frequently, not only once. Renal transplant biopsy to rule out any cause other than acute necrosis after 1 week better. Because the kidney within the first 5 days, it will be more congested from ischemia reperfusion injury, and it will be high risk for bleeding if you did biopsy earlier before within the first 5 days. Better to wait for 1 week at least. Important transplant surgical problem. What is the surgical problem common after transplant? Either vascular disease, ureteric stricture, perinephric fluid collection, wound dehiscence, or surgical site infection. Vascular disease, inadequate arterial flow may lead to hypoperfusion to the kidney or the legs. Extensive vascular calcification may make arterial anastomosis impossible. This is a common vascular problem during the transplant surgery. Ureteric stricture, most common seen in the distal portion of transplant ureter, may require balloon dilatation or surgical revision or permanent stent and to be changed frequently. Perinephric fluid collection, hematoma, lymphocyte, urinoma, and this should be differentiated by sending urine for creatinine and other chemistry, and wound dehiscence, especially for obese patient. If you have patient with BMI 30s and above, you should explain this in your pre-transplant workup. This your patient should know this complication post-surgery, maybe need longer hospitalization and wound care at home, and vac for this help to surgical wound dehiscence. ونكتفي بهذا القدر في هذا الفيديو، ونلتقي بكم في فيديو قريب بإذن الله، ونسألكم الدعاء بالتوفيق، والسلام عليكم ورحمة الله وبركاته.